system, that is hemorrhagic or hypovolemic shock. So, what is the prerequisite to understand this topic? The prerequisite is you must know the body fluid distribution. Okay, I guess all of you remember the body fluid distribution. In a 70 kg human being, total body water is 60% of body weight, right? So, say for example, I am 70 kg, my total body water will be 70 ka 60%, that is 42 kgs, and 42 kgs we can approximately consider it to 42 liters. So, total 42 liters of body water I have, right? Okay, 42 liters of body water. Now, out of this 42 liters, I have 2/3 intracellular fluid within the cell membrane, right? Within the cell membrane, and remaining 14 liter is extracellular fluid volume. Okay. Now, this extracellular fluid volume matters to us because this extracellular fluid volume is your effective circulatory fluid volume approximately. Okay. So, what is effective circulatory fluid volume? It is the part of extracellular fluid volume which is just adequate to maintain your mean arterial blood pressure, to maintain your tissue perfusion. Okay. Now, you have also got the concept of mean arterial blood pressure, which is the diastolic blood pressure plus 1/3 of pulse pressure. Okay. Diastolic blood pressure plus 1/3 of pulse pressure. It is your mean arterial blood pressure. And why mean arterial, maintaining a normal range of mean arterial blood pressure is important to us, right? To maintain mean arterial blood pressure within a normal range is important because it is the pressure head that determines your tissue perfusion. That means your lungs, your liver, your brain, your skin, or your kidneys, all of your organs are getting blood or getting perfused, getting nutrition, getting oxygen because of your mean arterial blood pressure. So, your mean arterial blood pressure is important to maintain your tissue perfusion, ताकि सारे organs में blood supply हो, ठीक है, right? And it is the mean arterial blood pressure that determines your tissue perfusion. Okay, and once the tissue perfusion is happening, your all organs are getting oxygen, your all organs are getting nutrition, right? So, maintaining tissue perfusion is important. So, maintaining a proper mean arterial blood pressure is also important to you, right? So, as the formula tells, mean arterial blood pressure is equal to diastolic blood pressure plus 1/3 of pulse pressure, and pulse pressure is equal to systolic blood pressure minus diastolic blood pressure, right? So, basically your mean arterial blood pressure depends on your systolic blood pressure, your diastolic blood pressure, right? But when your fluid volume or extracellular fluid volume is constant, right? If we consider your fluid volume is constant, you have no dehydration, you have no hypovolume status, right? You have no dehydration, you have no vomiting or any kind of fluid deficit you are having, okay? You have no fluid deficit, then only this formula is correct, okay? So, keeping your fluid volume constant, your mean arterial blood pressure is diastolic blood pressure plus 1/3 of the pulse pressure, okay? But if your volume changes, mean arterial blood pressure is supposed to change, right? If you have low volume, your mean arterial blood pressure is supposed to fall, right? So, primarily your mean arterial blood pressure and consequently your tissue perfusion depends on your volume status, okay? Primarily your mean arterial blood pressure and your tissue perfusion depends on the status of your volume. Okay, when the volume is normal, we call it U volume status. When the volume is high, we call it hypervolumic, right? And when the volume is low, we call it hypovolemic status, right? Okay. Now, let us define shock. Okay, define shock and remember this definition. Okay, so shock is the abnormality of the circulatory system that results in reduced organ perfusion and tissue oxygenation. So, it is definitely an abnormality of this circulatory system, okay? Abnormality in this circulatory system which results in reduced organ perfusion, number one, perfusion is not happening, and consequently tissue oxygenation is also not happening, right? What is the definition of hypoxia? You remember? Reduced oxygen tension at the level of tissue, okay, at the level of tissue, right? Reduced oxygen tension at tissue level, okay. Reduced oxygen tension in your arterial blood is called hypoxemia, MIA, right? Reduced oxygen tension, reduced partial pressure of oxygen, PaO2, right? So, reduced partial pressure of oxygen at arterial blood is called hypoxemia, and reduced oxygen tension at the level of tissue is called hypoxia, okay, hypoxia. Okay, so abnormality of the circulatory system that results in reduced organ perfusion, that means your vital organs, brain, liver, kidney, they are not getting adequate blood, number one, and number two, they are suffering from hypoxia, okay. So, tissue oxygenation is deficit, that means there is hypoxia, okay, clear. So, to define shock, two criteria, one is low tissue perfusion and another is hypoxia. Low tissue perfusion and hypoxia, these two are the things. Even if you do not remember the whole definition, 2 points to remember: reduced oxygen tension at the level of tissue, that is hypoxia, and reduced tissue perfusion, okay. Perfusion deficit and hypoxia, these two are the things to satisfy the definition of shock, okay. Okay, now there is a quote from Hippocrates. So, it says, it is a bad sign in acute illness when the extremities become cold, okay, hath pa thanda hoye geche, thik ache. It is a bad sign, any illness that subsequently leads to a situation where the extremities are becoming cold, hath pa thanda hoye geche, it is always a bad sign, thik hai, okay. So, it is a bad sign in acute illness when the extremities are cold, hath pa thanda hoye jawa kharap, ঠিক আছে, okay. I do not know how far this one is visible to you, okay. So, let us start from here. So, a case of hemorrhage, we are starting with a case of hemorrhage, simply blood loss, that may be a road traffic accident, that may be intraoperative blood loss or any kind of blood loss is there, okay. So, we start with this point, which is hemorrhage. It results in decreased central blood volume, okay. Primarily it causes decreased central blood volume and it leads to decreased arterial volume, and low pressure baroreceptors are activated, right. It sends signal to medullary cardiovascular control system, cardiovascular control center, and it causes high heart rate, increased contractility, arteriolar constriction, venous constriction, and increased release of renin and angiotensin 2 at the level of kidney. So, these are the 4 primary effects, and if we come from this side, hemorrhage, it leads to reduced venous return, okay, reduced venous return. It causes decreased stroke volume, and as there is decreased stroke volume, there will be reduced cardiac output, right. Reduced cardiac output will lead to decreased arterial pressure or mean arterial pressure. Again, it will activate the baroreceptor, but in this case it is high pressure baroreceptor. Again, this high pressure baroreceptor will activate the medullary cardiovascular control center, and finally these are the outcomes. So, the thing is, whenever there is hemorrhage, heart rate will increase contractility of the heart, arteriolar and venous constriction, and release of angiotensin and renin. Okay, this effect is quite late, but these are the immediate effect of hemorrhage. Okay, after hemorrhage, the immediate effect is heart rate increase, contractility of the heart is increased, veins and arteries will be constricted, right, and some late effect is increased renin and angiotensin secretion. So, what is the purpose of doing all these things? Basically, whenever there is hemorrhage, you are losing volume, right? You are losing volume, and go back to the concept of body fluid distribution, you have 42 liters of blood, out of which 28 liters is inside the cell and 14 liter is outside the cell. So whenever you are, we have not you, some patient, right? So whenever someone has hemorrhage, right? Whenever someone has hemorrhage, so he or she is losing volume from ECF or ICF? ECF, extracellular fluid volume, right? So as a result, the problem is decreased central blood volume and decreased venous return. So all these things are resulting in decreased mean arterial blood pressure, and they are trying to reduce tissue perfusion. Okay. So the thing is, whenever there is hemorrhage, volume loss, and this volume loss is causing decreased mean arterial pressure, right? And decreased mean arterial pressure matlab decreased tissue perfusion. That is satisfying the definition of shock. Okay, decreased tissue perfusion, and once this tissue perfusion is decreased, you have hypoxia as well, right? So it is satisfying the definition of shock, but you have homeostasis. Okay, your body tries to normal environment when it is subjected to change. The definition of homeostasis, it is the restoration of normal environment when it is subjected to change. So what parameter is changing in your body? Mean arterial pressure. Mean arterial blood pressure fall kore jacche, right? This parameter is changing, so your body will try to restore mean arterial blood pressure. How? By activating baroreceptors, right? By activating baroreceptors, and baroreceptor will send signal to the NTS, nucleus tactus solitarius, in your brainstem, and the output is coming from brainstem to heart and blood vessels, and these are kidneys, and they are causing increased heart rate and contractility. Blood vessel guloke narrow kore dicche, arteriolar and venous constrictions, and finally your mean arterial blood pressure is increasing. Okay, so this much support you are getting from your homeostatic mechanism. Okay, so that hemorrhage is not so as to not harm you, right? Okay, so hemorrhage jate kono khoti korte na pare, your body is doing some compensatory mechanism to restore mean arterial blood pressure, jate tissue perfusion maintain thake, jate hypoxia na hoy, right? So your body is trying to restore, and this is the mechanism. But yes, it has got a limit. Okay, it cannot be, continuous hemorrhage and your body will do homeostatic mechanism and maintain your mean arterial blood pressure. That is not possible. It has got a limit. Okay, and once the limit is crossed, things become irreversible. Okay, it cannot be restored back to the normal state, right? Okay, we are coming to it. Okay, so starting from this is mean arterial blood pressure, say it is 100, right? Mean arterial blood pressure 100. So it is after hemorrhage, mean arterial blood pressure falls to this point, okay, falls to this point, and by homeostatic mechanism it tries to restore. Okay, but here is a point. From this point, it is a crucial point or critical point where things may become irreversible, and this is the purpose of our treatment. So that this is the purpose of treatment. You treat the patient, okay, you treat the patient to maintain mean arterial blood pressure, to maintain mean pressure, to maintain perfusion, okay, and take the curve to this way, not this way, right? Clear? Okay. Now, this is already discussed, body fluid distribution. Okay, so first what we do, the thing is blood for blood. If there is blood loss, we need to infuse blood, right? Blood for blood, that is the best option, right? But the patient is arriving with hemorrhage, maybe unconscious, right? Immediately blood may not be available. Okay, immediately blood may not be available, and you need to do blood grouping, cross matching as well, right? So immediately what we can do, we can infuse some normal saline. Okay, now what is the problem with normal saline? So since sodium equilibrates through the extracellular fluid, Normal saline means 0.9% NaCl. Okay, 0.9% NaCl. लोग जब वर्ड में जाओगे तो देखना कि बॉटल में क्या लिखा है, ठीक है, composition 0.9%, it is 0.9% NaCl. Okay, so since sodium equilibrates through the extracellular fluid, 75% of the infused saline solution will distribute in interstitial fluid and 25% will distribute in plasma. Okay, initially it is remaining in the interstitial fluid. Okay, ISF, interstitial fluid. Okay, thus the principal effect of saline solution is to enhance the interstitial fluid volume and not the plasma volume. Okay, because your blood loss is from plasma volume. Okay, you have lost the patient has lost blood from intravascular compartment. You remember the further subdivision of extracellular fluid volume. Out of this 14 liter, 3.5 liter is blood volume. Okay, 3.5 liter is blood volume and remaining 10.5 liter is ISF, interstitial fluid volume. Okay, and blood volume and interstitial fluid volume, they are exchangeable. Okay, through the capillary, they are exchangeable, right? So if you infuse 1 liters of normal saline, primarily out of this 1 liter of normal saline, 250 ml remains in the intravascular compartment. 250 ml remains in the intravascular compartment and remaining 750 ml goes to ISF, interstitial fluid. Okay, interstitial fluid. Okay, so our purpose is not exactly served because 25% purpose is served and 75% purpose is not served. Okay, আমার ভালো হতো যদি নরমাল স্যালাইন পুরোটাই ইন্ট্রাভাস্কুলার কম্পার্টমেন্টে থেকে যেত, ঠিক আছে, যেটা আমার মিন আর্টারিয়াল ব্লাড প্রেশারটাকে মেইনটেইন করছে, রাইট? ওকে, ওকে, now we will classify basically hemorrhagic shock. Okay, so what is the purpose of our discussion? Number 1, define shock, যেটা আমরা অলরেডি করেছি। ওকে, শকের ডেফিনিশন আমরা দিয়েছি। দেন we need to classify shock. Okay, and monitoring shock and the markers by which you can classify the patient. Monitoring shock, ठीक है, कि आप कैसे समझोगे कि which patient is class 1, which patient is class 2, class 3 and class 4. So here we will classify shock into 4 categories. One is class 1 shock, class 2 shock, class 3 shock and class 4 shock. Definitely the severity is increasing. Okay, class 1 is not severe and class 4 is definitely a severe. Okay, that may be irreversible even after treatment. Okay, even after treatment you may lose the patient, right? Okay, so this classification is according to the American College of Surgeons, right? So what is class 1 shock? Class 1 shock is less than 15% of blood volume. Okay, at least you remember this. Okay, per kg maybe yaad rakh sakte ho, right? So loss of less than 15% of blood volume. Okay, very simple, less than 15 to 30, 30 to 45 and more than 45%. Class 1, class 2, class 3 and class 4. I am coming in subsequent slide, right? So class 1 shock is less than 50%. So this degree of blood loss is usually fully compensated by transcapillary refill. Okay, so I told you previously in previous classes that this intravascular fluid volume IVF and ISF, these are exchangeable. So what is your immediate support after shock? Okay, you have many compensatory mechanisms, right? We have discussed many compensatory mechanisms like low pressure baroreceptor, high pressure baroreceptor, and after some time kidney compensates by secreting renin and subsequently formation of angiotensin 2, right? So there are lots of homeostatic mechanism that supports the patient after hemorrhage, right? But the immediate support is transcapillary refill, immediate support. Okay, and how this transcapillary filling takes place? Intravascular fluid volume and interstitial fluid volume. These two are exchangeable, and in between what is there? Capillary. Okay, so through the capillary, ISF can support IVF, IVF can support ISF. Okay, so once there is hemorrhage, the patient is losing volume from here. The patient is losing volume from here, right? So ISF will back it up, okay, by doing transcapillary refill. Some fluid will be here through transcapillary filling, okay. And once the hemorrhage is class 1 hemorrhage, it is fully compensated by transcapillary filling, right? And because the blood volume is maintained, finally the blood volume is maintained and the clinical findings are minimal or absent and the volume resuscitation is not necessary. At this level, no treatment is required. Okay? So, up to 15% of blood loss, there is no symptoms, or even if there are symptoms, it is very minimal and no treatment is required. Okay, no treatment is required because transcapillary refill will compensate fully. Okay. Class 2, 15 to 30% of blood loss. Okay, very easy to remember. Less than 15, 15 to 30, 30 to 45 and more than 45. Okay, so now class 2 hemorrhage. This represents the compensated phase of hypovolemia where blood pressure is maintained by systemic vasoconstriction. Okay, systemic vasoconstriction, that is the direct effect of high pressure and low pressure baroreceptors. That has been shown in the flow chart, right? So your immediate support is transcapillary refill. Next support is baroreceptor chemoreceptor, and last support is your renin-angiotensin mechanism. These are homeostatic mechanism coming into action, right? So how homeostatic mechanisms coming into action in a sequence? In a sequence, the immediate support is transcapillary refill. Second support is high pressure and low pressure baroreceptor, ek saath. And the third support is renin-angiotensin system. But renin-angiotensin system, the support by kidney, it takes time. Okay, it takes time. Okay. Always neural mechanisms are more advanced and quick neural mechanism, because baroreceptor, chemoreceptor, these are all neural mechanism. Everyone, I guess all of you know. So neural mechanism is faster than hormonal mechanisms. Okay. Okay. So class 1, यहाँ पर no requirement of baroreceptor things and no requirement of kidney support as well. Only transcapillary refill, that is enough. Okay, that is enough and the patient is okay. Okay, but here where blood loss is 15 to 13%, 15 থেকে 30% blood loss হয়েছে, ঠিক আছে? Now this represent the compensated phase, মানে baroreceptor, chemoreceptor এগুলো কাজ করে তারপর patient okay আছে, ঠিক আছে? So this represent the compensated phase of hypovolemia where blood pressure is maintained by systemic vasoconstriction. Baroreceptor, high pressure and low pressure baroreceptor কাজ করে কি হচ্ছিল? Heart rate increase করছিল, contractility increase করছিল and arteriolar and venous constriction হচ্ছিল, right? So এই সবকটা করে mean arterial blood pressure maintain হয়ে যাচ্ছে. This is the thing what is happening here in class 2. ঠিক আছে? So this represent the compensated phase of hypovolemia where blood pressure is maintained by systemic vasoconstriction. Postural changes in the pulse rate, postural change টা তোদের প্র্যাকটিক্যালে হয়েছে নাকি খালি এক্সারসাইজে হয়েছে? postural হয়েছে? Okay. So postural changes in pulse rate and blood pressure may be evident, but these findings are inconsistent and the hypovolemia can be clinically silent. ঠিক আছে? মানে পেশেন্টকে সুপাইন পজিশন থেকে দাঁড় করিয়ে দিলে যা চেঞ্জ হয়, পালস রেট বাড়ে, ঠিক আছে? তো যদি হাইপোভলিমিয়া থাকে তাহলে সেটা বেশি বাড়বে, বাট এই ফাইন্ডিংটা এখানে খুব ইনকনসিস্টেন্ট, সুতরাং এই ফাইন্ডিংটার উপর আমরা খুব একটা ডিপেন্ড করি না, রাইট? The vasoconstrictor response to hypovolemia is most intense in this splanchnic circulation. Very important, very important. ठीक है? Your high pressure baroreceptor and low pressure baroreceptors are stimulated. They are sending signal to brainstem. From brainstem, output signal is coming to as sympathetic output to your heart and blood vessel. And finally, there is vasoconstriction, arteriolar constriction, and venous constriction. But the effect of this constriction is much more evident in this splanchnic circulation. Okay, much more evident in this splanchnic circulation, right? So, one thing that can happen here in class 2 hemorrhage, okay, this is also a state which is compensated, okay, that means clinically silent, okay, you cannot, you check the patient and there may not be any evidence of low mean arterial blood pressure. Okay, you can measure mean arterial blood pressure and there might be mean arterial blood pressure will be showing normal because baroreceptor and baroreceptor, low pressure and high pressure baroreceptor, by doing vasoconstriction they have already compensated mean arterial blood pressure. Okay, but mean arterial blood pressure is already compensated, but one thing may not be compensated, that is volume. ठीक है, volume तो कमे ही गए, right? Volume कमे गए, ता सत्त्वेও low pressure and high pressure baroreceptor, they are activated and they have restored mean arterial blood pressure, but there may be hypovolemia. ঠিক আছে? So সেই hypovolemiaটা ডিটেক্ট করতে গেলে I can do postural challenge. Okay, postural challenge, patient কে supine করে pulse rate দেখতে পারি, ঠিক আছে, and pulse rate will be high, but that finding is inconsistent. There might be hypovolemia, right? Okay, and remember this is also true that throughout the body vasoconstriction is not uniform. যে বডির সমস্ত সার্কুলেশনে, ব্রেনের সার্কুলেশনে, লাংসের সার্কুলেশনে, কিডনি সার্কুলেশনে সব জায়গায় যে ইকুয়াল ভ্যাসোকনস্ট্রিকশন হলো তা না। ভ্যাসোকনস্ট্রিকশন ইজ অ্যারাউন্ড দিস স্প্ল্যাঙ্কনিক সার্কুলেশন, ওকে, GI tract, renal, okay, around the splanchnic circulation vasoconstriction is maximum. So what can be the consequence? Splanchnic hypoperfusion, as there is narrowing of the blood vessels in the splanchnic circulation. So splanchnic hypoperfusion can lead to disruption of the intestinal mucosa and invasion of the bloodstream with enteric pathogen. Okay, so some degree of hypoxia around the GI tract, okay, some degree due to vasoconstriction, and as a result of this there might be invasion of the bloodstream with enteric pathogen, okay, the bacteria which are in the GI tract that may invade bloodstream. So this is one of the major effect in class 2 hemorrhage. Even if mean arterial blood pressure is controlled due to splanchnic superconstriction, splanchnic vasoconstriction, okay, due to splanchnic vasoconstriction, the effect is there in and around the GI tract. Okay, there might be low perfusion, there might be tissue hypoxygenation, that is hypoxia, and that may lead to enteric pathogen to enter into the bloodstream, and that might be the source of a major infection. Okay, class 3 পার্সেন্টেজ সবার মুখস্থ হয়ে গেছে তো, পার্সেন্টেজ তো খুব সোজা। ওকে, ক্লাস 1 মানে 15% এর নিচে, ক্লাস 2 মানে 15 থেকে 30, ক্লাস 3 মানে 30 থেকে 45, and ক্লাস 4 মানে 45 এর উপরে। ওকে, সো ক্লাস 3 hemorrhage, loss of 30 to 45% blood volume, 30 to 45% blood volume, and this marks the onset of decompensation. So class 3 is the situation where compensation will not work. Transcapillary refill ও কাজ করবে না, baroreceptor low pressure and high pressure baroreceptor এর support ও কাজ করবে না, right? So beginning of decompensation is at 30%. Okay, beginning of decompensation is at 30% blood loss. Vasoconstrictor response is no longer able to sustain mean arterial blood pressure and organ perfusion. That is the most important line. Okay, vasoconstrictor response by high and low pressure baroreceptor is no longer able to sustain blood pressure, mean arterial blood pressure, and tissue perfusion. Okay, and the clinical consequence can include supine hypotension, evidence of impaired organ perfusion. Here comes the cool extremities. Okay, inadequate organ perfusion. As a result, clinically what you see, cold extremities, হাত পা ঠান্ডা হয়ে যাচ্ছে, right? Cold extremities, oliguria, reduced urine volume and depressed consciousness. Okay, so this is the starting point of decompensation. You will get all the clinical signs of reduced organ perfusion. You will get all the clinical signs of reduced organ perfusion. Okay, and the result is cold extremities, oliguria, low urine volume, right, and depressed consciousness. Patient will lose consciousness, right? Okay, and the evidence of anaerobic metabolism, lactate accumulation in blood, starting point. Okay, as there is reduced oxygenation, there will be anaerobic metabolism. Okay, and with anaerobic metabolism, you know from your biochemistry knowledge, there is accumulation of lactic acid. Okay, so 30% is the starting point. 30% of blood loss is the starting point of decompensation. 30% is the starting point where lactate starts to accumulate in the patient's body, right? So very important checkpoint, 30%. Okay, and you need to treat immediately, right? Class 4, more than 45% blood loss. The degree of blood loss results in profound hemorrhagic shock which may be irreversible. Okay, more than 40% things may be irreversible. Even after treatment, you may not be successful to restore or revive the patient, right? More than 40%, class 4. Okay, so clinical manifestation include multi-organ failure, severe metabolic acidosis, lactic acidosis, severe metabolic acidosis. Okay, okay, now I guess all the classes are clear to you. Okay, now I am coming to another important part. So little bit discussion. Class 3. হ্যাঁ, তো ইমিডিয়েটলি তো হচ্ছে না, ইমিডিয়েটলি তো হচ্ছে না। আমি যখন স্যালাইন ইনফিউজ করছি তো মেজর পার্ট ইজ গোয়িং টু ইন্টারস্টিশিয়াল ফ্লুইড, ঠিক আছে, কিছুটা এখানে আসছে। ওকে, ওকে, সো নাও, so what is compensatory? There are basically two compensatory mechanisms you already know. So fast immediate compensatory, we have already discussed it. So fast immediate compensatory mechanism is transcapillary refill, right? Second compensatory mechanism is neural reflexes, that is low pressure and high pressure baroreceptor reflex. And third compensatory mechanism is by renin-angiotensin-aldosterone system. Okay, so the earliest response involve movement of interstitial fluid into the bloodstream. This transcapillary refill can add as much as 1 लीटर, इसका भी एक लिमिट है, ठीक है। By doing transcapillary refill, maximum compensation can be done up to 1 liter. By doing transcapillary refill, right? Now the second compensatory mechanism involved the renin-angiotensin-aldosterone system, which results in sodium conservation by the kidney. But remember, it takes time, right? It takes time. The retained sodium will primarily enhance the interstitial volume and thus will help to replace the interstitial fluid deficit created by transcapillary refill. It actually transcapillary refill টাকেই সাপোর্ট করছে, right? This renin-angiotensin-aldosterone system. Renin-angiotensin-aldosterone system কি করছে? এটা সোডিয়ামকে রিটেইন করতে সাহায্য করছে, so that sodium is not washed out in urine, right? And secondarily, it is increasing volume in the interstitial fluid. Okay, কারণ interstitial fluid থেকে কিছুটা ভলিউম ইন্ট্রাভাস্কুলার কম্পার্টমেন্টে চলে গেছে, তার জন্য তো interstitial fluid এর ডেফিসিট হয়েছে, right? Interstitial fluid এর ডেফিসিট হয়েছে, সেই ডেফিসিটটাকে কম্পেনসেট করছে renin-angiotensin-aldosterone mechanism, right? Okay, and these two responses can fully compensate for the loss of 15 to 20% of blood volume. এই দুটো মেকানিজম মিলে ম্যাক্সিমাম 15 to 20% of the blood volume compensate করতে পারছে। Now why there is decompensation? Why there is decompensation? Failure কেন হচ্ছে? ঠিক আছে, compensatory mechanism fail কেন করছে? Okay, so number one, there are many causes. Desensitization of vascular adrenoceptors. Okay, catecholamine receptor. ক্যাটেকোলামাইন রিসেপ্টর গুলো মানে অ্যাড্রিনালিন, নরঅ্যাড্রিনালিন যে রিসেপ্টর গুলো যেগুলো দিয়ে সিম্পাথেটিক আউটপুট হয়, ওকে, হার্ট রেট বাড়ে বা ভেসোকনস্ট্রিকশন হয়, রাইট? সো ক্যাটেকোলামাইন রিসেপ্টর গুলো আইদার ডিপ্লিট হয়ে যাচ্ছে অথবা ডিসেন্সিটাইজড হয়ে যাচ্ছে। সেকেন্ড থিং ইজ ইসকেমিক টিস্যু, দ্য টিস্যু হুইচ ইজ নট গেটিং অ্যাডিকুয়েট অ্যামাউন্ট অফ ব্লাড, দ্য ইসকেমিক টিস্যু, ইট রিলিজেস মেটাবোলাইটস। ইসকেমিক টিস্যু থেকে অনেক মেটাবোলাইট বেরোয়, ওকে, অ্যাডিনোসিন, পটাশিয়াম, রাইট? সো দিস মেটাবোলাইটস আর বেসিক্যালি ভেসোডাইলেটর, right? Once the tissue is ischemic, they release some metabolites into the bloodstream, okay, and these metabolites are vasodilator, that negates the effect of sympathetic system of vasoconstriction. Sympathetic system is trying to do vasoconstriction, okay, but the released metabolite from the ischemic tissue, they are negating this effect and they are doing vasodilation, okay. So, ischemic tissue releases metabolites and other vasodilator substances that act on the local blood vessel, okay. So, local blood vessel vasoconstriction effect thakche na due to release of metabolites, okay, and failure of capillary refill, third, and fourth cause is acidosis, means high H plus, right. It can exchange with calcium. So, acidosis reduces calcium in the myocardium and that reduces the contractility as well, okay. For your cardiac muscle to contract, you need calcium, okay. But once there is acidosis, okay, this calcium, intracellular calcium level depletes and as a result the contractility of heart is also decreased. And once this heart is not contracting adequately, again mean arterial blood pressure falls, right, okay. And third thing, final thing is prolonged cerebral ischemia, okay. Once there is ischemia here, because you know the low pressure baroreceptor, high pressure baroreceptor, their control center is in the brain stem, okay. Once your brain stem is not, the patient's brain stem is not getting adequate blood, brain stem is suffering from hypoxia, how the neural mechanism is supposed to work, right. The baroreceptor reflex, low pressure baroreceptor reflex, high pressure baroreceptor reflex, they will not work because the brain and the brain stem, they are also suffering from hypoxia. So, neural mechanism is also got damaged, right. Okay, so prolonged cerebral ischemia depresses neural activity throughout the brain, thereby weakening the sympathetic output. That sympathetic output which is supposed to do vasoconstriction. Okay, say sympathetic output tai hocche na, clear? So, these are the causes of decompensation. Keno compensation hocche na, keno homeostatic fail kore jacche, keno homeostasis fail kore jacche once the blood loss is more than 30%, okay, because 30% is the point where compensation is starting to fail, okay, homeostatic mechanism is starting to fail, okay. Now, the clinical evaluation, you need to classify the patients and this is class 1, this is class 2, this is class 3, this is class 4, okay. In the ward, in the ICU, you have many patients, someone will be class 1, class 2, class 3, class 4, you need to segregate the patient, right. So, on which basis, how to determine this patient is class 1, this patient is class 2, because you know how much that may be, there may be errors in the history, because you can ask the patient or patient party how much blood has been lost, okay, and that is spurious actually, right. Exact history tumi pabe na ki patient er koto % blood loss hoyeche, it is very difficult to determine, right. Okay, now you need to evaluate the patient, okay. So, evaluation is really very much difficult. How to evaluate the patient, whether it is class 1 or class 2 or class 3, it is really difficult. Okay, every point, all points you don't need to know at your level, but few points are, yes, very important, right. So, clinical evaluation of the intravascular volume, amake jante hobe volume kotota ache, thik ache, volume ja thakar kotha tar koto % komeche ar ki, tobei to ami classify korte parbo, right. So, clinical evaluation of intravascular volume is so flawed, so fallacious that it is called a comedy of errors, okay. But still, let us try how to evaluate the patient, okay. So, these are studies, amra ki dekhbo, so ekhane dekhchi je onek gulo parameter amra dekhchi, supine tachycardia, supine hypotension, mane patient er pulse rate fall korte pare, patient er pulse rate badhte pare, supine tachycardia, supine hypotension, supine অবস্থায় blood pressure fall করতে পারে, postural pulse increment, patient কে দাঁড় করালে pulse rate বেড়ে যাচ্ছে, okay, and postural hypotension. So, it has been seen that postural pulse increment, it has got the highest sensitivity and specificity. So, you can rely on that parameter, বাকি parameter গুলো খুব একটা reliable না, right. So, postural pulse increment, sensitivity and specificity both are more than 95%, okay. You don't know what is sensitivity and specificity, so it is a separate topic, we will discuss again, okay. So, it is discussed under in community medicine, okay. So, any test has got a sensitivity and a specificity, okay. Sensitivity is excluded true, negative, okay. Anyways, we will discuss after some time. So, postural pulse increment, it is the most reliable thing that we can depend on, okay. Postural pulse rate increment, but একটা severe patient কে তো তুমি দাঁড় করাতে পারবে না, একটা unconscious patient কে তো দাঁড় করাতে পারবে না, right, okay. Anyway, so up to certain point postural pulse increment, we can depend on this parameter. You know the basic mechanism why after standing pulse rate increases. I guess everyone know, practical class is done. The effect of posture and exercise on pulse rate and blood pressure, that has been discussed, right? Riddhit sir পড়িয়েছে, right? Okay. Now the vital signs supine tachycardia and hypotension are absent in large majority of the patient with blood volume deficit up to 1.1 liter. Postural changes. So moving from supine to standing position, normally moving from supine to standing position causes a shift of 7 to 8 ml per kg of blood in the lower extremity. Lower extremity te extra 7 to 8 ml per kg blood move hoy, right? In healthy subject, this change in body position is associated with a small increase in the heart rate, 10 beats per minute, okay, and a small decrease in the systolic blood pressure. This change can be exaggerated in hypovolemia. ঠিক আছে, নর্মালি একটা নর্মাল হেলদি ইন্ডিভিজুয়াল যদি শুয়ে থেকে উঠে দাঁড়ায় তাহলে পালস রেট ইজ সাপোজ টু ইনক্রিজ বাই 10, ওকে, বাই 10 per minute, ওকে, বাট দিস ইজ এক্সাগারেটেড when the patient is hypovolemic, ওকে, এটা অনেক বেশি হয়, 10 এর জায়গায় ওটা 20-30 বেড়ে গেল, রাইট? ওকে, the expected postural changes in hypovolemia include an increment in pulse rate of at least 30, okay, at least 30 beats per minute, and a decrease in the systolic blood pressure that exceeds 20 millimeter of mercury, okay. So this is the postural change that we can depend upon to assess the volume status of the patient. Okay, now hematocrit, you know what, everyone knows what is hematocrit, right? Okay, so acute blood loss involve loss of whole blood, right? You are losing whole blood, which results in proportional decrease in the volume of plasma and erythrocyte. ঠিক আছে, when the patient is losing blood, প্লাজমাও কমছে, এরিথ্রোসাইটও কমছে, রাইট? এমন তো নয় যে আরবিসি গুলো বাদ দিয়ে শুধু প্লাজমাটা বেরিয়ে যাচ্ছে, তা তো নয়, টোটাল ব্লাডটাই বেরোচ্ছে, রাইট? ওকে, as a result, acute blood loss result in decrease in blood volume but not a decrease in hematocrit. তাই তুমি হেমাটোক্রিটের উপর ডিপেন্ড করতে পারবে না, ঠিক আছে? তুমি ব্লাড লস হওয়ার পর যদি হেমাটোক্রিট দেখবে একই আছে, তাই তো? হেমাটোক্রিট এর পার্সেন্টেজ কত পার্সেন্ট রয়েছে, 45% কি 50%, 45% হেমাটোক্রিট রয়েছে, বাকিটা প্লাজমা রয়েছে, পড়েছো, রাইট? ওকে, সো ওয়ান্স blood loss is there, plasma and RBC both are washed out simultaneously, okay. So if you perform hematocrit value, it will remain same, okay. So see this acute hemorrhage, hematocrit 45%, 45%, ঠিক আছে? এখানেও after acute hemorrhage this is normal and this is 45%, একই থাকছে, টোটালটা কমেছে, প্লাজমাও বেরিয়ে গেছে, সেলও বেরিয়ে গেছে, আবার হেমাটোক্রিট 45%ই থাকছে, ক্লিয়ার? আচ্ছা, এবার সেলাইন রিসাসিটেশনের প্রবলেমটা কি? যখন তুমি সেলাইন রিসাসিটেশন করছো, মেবি mean arterial blood pressure is restored, maybe mean arterial blood pressure is restored, but hematocrit will fall. তুমি তো আরবিসি দিচ্ছ না পেশেন্টকে, ফ্লুইড দিচ্ছ, রাইট? নাও হেমাটোক্রিট will fall, রিসাসিটেশন। কিন্তু যখন হোল ব্লাড দিচ্ছি পেশেন্টকে, হেমাটোক্রিট রেস্টোর হচ্ছে, 45% হচ্ছে, ওকে। সো বেস্ট ইজ অলওয়েজ ব্লাড ফর ব্লাড, ব্লাড লস হয়েছে, সো ব্লাড দিতে হবে, তাহলে আমার হেমাটোক্রিটও ঠিক থাকছে, ক্লিয়ার? Okay, now cardiac filling pressure or central venous pressure, cardiac filling pressure or central venous pressure, right atrial pressure, okay, right atrial pressure, central venous pressure measurement has been মানে এটাও চিন্তা ভাবনা করা হয়েছিল যে whether central venous pressure, if we measure central venous pressure, it can correlate with the amount of blood loss or not, ঠিক আছে? because blood loss হলে central venous pressure fall করবে, this is the basic idea, okay. But this is also not very much reliable parameter because lack of correlation between central venous pressure and circulating blood volume measurement has prompted the recommendation of central venous pressure should never be used to make decision regarding fluid management, ঠিক আছে? So this is the graph, এখানে দেখা যাচ্ছে যে খুব একটা কোরিলেট করছে না, ঠিক আছে, central venous pressure আর volume. Okay, now systemic oxygen consumption, okay, systemic oxygen consumption, এখান থেকে আসছি পিকচারটা থেকে। ওকে, so systemic oxygen consumption VO2 is the delivery of oxygen into oxygen extraction. Okay, oxygen extraction মানে কি, arterial blood এ oxygen saturation আর venous blood এ oxygen saturation তার difference, because artery is supplying the organ, oxygen supply করছে artery, তারপর সেই organ থেকে vein আসছে, রাইট, তার মানে অক্সিজেনটা ডেলিভার করে অর্গানে ডেলিভার করে তারপরে ভেনাস ব্লাড তৈরি হচ্ছে, রাইট। ওকে, তাহলে আর্টারিয়াল অক্সিজেন স্যাচুরেশন থেকে ভেনাস অক্সিজেন স্যাচুরেশন আমি যদি বাদ দিই তাহলে টিস্যু এক্সট্রাকশন পাবো, টিস্যু কতটা অক্সিজেন নিয়ে নিল, ঠিক আছে। ওকে, তাহলে VO2 is equal to delivery of oxygen into the tissue extraction, right? Okay, now this is the normal situation, this is the normal situation, okay, where SaO2 98% and SVO2 73%, right, normal situation. Okay, now here এখানে ম্যাক্সিমাম এক্সট্রাকশন হচ্ছে, এখানে 98%, এটা 50%, তাহলে এক্সট্রাকশন বেশি, বাট VO2 remains same because DO2 is decreased, right, delivery of oxygen is decreased. Okay, মানে এখান থেকে এখানে আস্তে আস্তে কি হচ্ছে, this is DO2, this line is x axis is DO2, delivery of oxygen. Okay, তাহলে এখানে হচ্ছে 600 ml per minute per meter square, 400 ml per minute per meter square, আস্তে আস্তে DO2 কমছে, রাইট, DO2 কমছে, but VO2 is remaining same, VO2 is remaining same because DO2 is decreasing. Okay, DO2 is decreasing, this one extraction is increasing, এখানে extraction high, right, এখানে extraction high, 98 minus 50, okay, 98 minus 50 मतलब কত হয় 48, okay, এখানে extraction 48 আর এখানে extraction 25, extraction 25, okay, tissue extraction 25, okay, তাহলে 25 into 600, 25 into 600 আর এখানে হচ্ছে 48 into around এটা কত 250, ঠিক আছে, দিয়ে টোটাল আমার VO2 টা সেম রাখছে, ওকে, দিয়ে VO2 টা সেম থাকছে, বাট আফটার দ্যাট এটা মেইনটেইন হচ্ছে না, মানে এই পর্যন্ত আমার কম্পেনসেশন হয়ে যাচ্ছে, রাইট, এই পর্যন্ত কম্পেনসেশন হয়ে যাচ্ছে, তারপরে যখন DO2 ডেলিভারি অফ অক্সিজেন আরো কমে যাচ্ছে তখন টিস্যু হাইপক্সিয়া শুরু হচ্ছে। So this part is the phase of compensation. Okay, this part is the phase of compensation. Even after decreased delivery of oxygen, even after decreased delivery of oxygen, even after decreased delivery of oxygen, tissue utilization of oxygen is remaining the same. Okay, tissue utilization of oxygen is remaining the same, right? Okay, because extraction is increasing. Even if DO2 is decreasing, extraction is increasing. Okay, তাহলে এই পয়েন্টে যা আছে, এই পয়েন্টে কি হচ্ছে, DO2 কমে যাচ্ছে, এক্সট্রাকশন বেড়ে যাচ্ছে, আলটিমেটলি VO2 is remaining same. Clear? Okay. Now, final slide and the last slide. Okay. Now, most reliable parameter by which you can determine the volume status is the serum lactate. Okay, it is a marker of tissue dysoxia. Still now the most reliable marker. Okay, আমরা আগে কতগুলো প্যারামিটারের উপর ডিপেন্ড করছিলাম, ঠিক আছে, যেমন পশ্চুরাল পালস ইনক্রিমেন্ট, এটা বেশ রিলায়েবল ছিল, ঠিক আছে, বাট সব পেশেন্টের ক্ষেত্রে করতে পারছি না, রাইট। সেন্ট্রাল ভেনাস প্রেসার খুব একটা রিলায়েবল হচ্ছে না, রাইট। আচ্ছা, তারপরে VO2 যদি মাপতে যাই, ঠিক আছে, টিস্যু ডেলিভারি অফ অক্সিজেন, বাট এই প্যারামিটারগুলো একটা অ্যাকিউট পেশেন্টের ক্ষেত্রে মেজার করা খুব ডিফিকাল্ট। ওকে, আমি ম্যাক্সিমাম স্যাচুরেশন মেজার করতে পারছি, ডেলিভারি অফ অক্সিজেন, টিস্যু ইউটিলাইজেশন অফ অক্সিজেন, এগুলো একটা অ্যাকিউট সেটিংয়ে মেজার করা খুব ডিফিকাল্ট, ঠিক আছে, ওটা দিয়েও আমি খুব একটা কিছু করতে পারছি না, ঠিক আছে। সো ফাইনালি আই এম কামিং টু দিস সেরাম ল্যাকটেট। অ্যানারোবিক মেটাবলিজম কোন পয়েন্ট থেকে শুরু হয়েছিল, কত পার্সেন্ট অফ ব্লাড লস থেকে শুরু হয়েছিল? অ্যানারোবিক মেটাবলিজম 30%। 30% ইজ দ্য বিগিনিং, মানে ক্লাস 3 থেকে আমার ডিকম্পেনসেশন শুরু হয়েছিল, ক্লাস 3 থেকে কি শুরু হয়েছিল? অ্যানারোবিক মেটাবলিজম, ঠিক আছে, মানে ল্যাকটেট অ্যাকুমুলেশন শুরু হয়েছিল। ওকে ওকে, তার মানে যখনই ল্যাকটেট আসছে, ব্লাডে ল্যাকটেট আসছে যখন, definitely it is more than 30% blood loss. Clear? যখনই ব্লাডে ল্যাকটেট আসছে, it is the beginning of decompensation, beginning of anaerobic metabolism, right? Beginning of anaerobic metabolism and the start of decompensation. ঠিক আছে? মানে ক্লাস 3 তে ঢুকছে, ল্যাকটেট একটু পাচ্ছ মানেই ক্লাস 3 তে ঢুকছে। ওকে, সো অ্যাক্টিভ হেমারেজ ক্যান রিডিউস দ্য সিস্টেমিক অক্সিজেন ডেলিভারি টু এ লেভেল দ্যাট আর unable to sustain aerobic energy metabolism. This resulting oxygen limited metabolism is called dysoxia. Oxygen limited metabolism, it is called dysoxia, and it is accompanied by enhanced production of lactate via anaerobic glycolysis. ঠিক আছে, পুরোটা anaerobic pathway দিয়ে হচ্ছে, anaerobic glycolysis, and the threshold is 2 millimole per liter. Threshold for elevated serum lactate is 2 millimole per liter. মানে 2 millimole per liter যখনই ক্রস করছে, the patient is entering from class 2 to class 3. ঠিক আছে, 2 millimole per liter যখনই ক্রস করছে, the patient is entering class 2 to class 3, right? And that is the point where you need to treat the patient vigorously, right? Okay, and the lactate levels of more than 4 millimole per liter are predictive of increased mortality. যদি ল্যাকটেট লেভেল 4 মিলিমোল পার লিটারের বেশি হয়, তাহলে দেয়ার আর চান্সেস অফ মর্টালিটি। ঠিক আছে, and the normalization of lactate level within 24 hours can be used at the end point of resuscitation. आप पेशेंट को ट्रीट करोगे, ट्रीटमेंट আমি ডিসকাস করছি না, because it is not under physiology. Okay, treatment will be discussed in medicine. ঠিক আছে, ওকে, সো নর্মালাইজেশন তাও একটা লাইন বলে দিচ্ছি যে কতক্ষণ ট্রিট করব পেশেন্টকে, যতক্ষণ না ল্যাকটেট লেভেল আমি নর্মাল করতে পারছি। উইদিন 24 আওয়ার্স আমাকে ল্যাকটেট লেভেল নর্মালাইজ করতে হবে। দ্যাট ইজ দ্য এন্ড পয়েন্ট অফ ইউর রিসাসিটেশন। ঠিক আছে, পেশেন্টকে যে ট্রিটমেন্ট করবে তার এন্ড পয়েন্ট কোনটা, আমার ল্যাকটেট লেভেল নর্মাল হয়ে গেছে। ঠিক আছে, ওকে।